afternoon to contribute. They've all been invited to stay for the duration and to participate in discussion at the end. We've been clear to all of the witnesses this afternoon that they have 7 minutes to make their presentation, and then there will be 10 minutes of Q&A to follow. And we do have to stick quite rigidly to that, so we will intervene if you carry on beyond 7 minutes, simply because we don't want to cut off or shorten the time available for those coming later on. And the two final points to make is that, or the final point to make is that there are two key questions which we're focusing on throughout this inquiry. First, what does good health devolution look like in both building a community's health and improving a community's health services? Two slightly different but overlapping questions. And secondly, what are the implications of health devolution for accountability, power and control? And so we now move to the calling of witnesses. And can I first of all warmly welcome Councillor Ian Hudspeth, Chair of the Community Wellbeing Board at the LGA. Ian, 7 minutes for your presentation. Do please start.
Thank you very much, and thank you for inviting me. Not only am I chairman of the Health and Wellbeing Board, the Community Wellbeing Board, I'm also leader of Oxfordshire County Council. The LGA is a politically led cross-party membership organisation representing councils from England and Wales. We support councils to deliver local solutions to national problems, so devolution is very close to our hearts. You asked some specific points, but I'd just like to mention some key messages from the LGA. Devolution is not an end in itself. It's about the outcomes that can be achieved through transfer of power and resources, and those resources have to be sufficient for the task. It's about building governance up from neighbourhoods and places so that what cannot be planned and delivered at neighbourhoods or place level should be carried out at system level. The NHS and local government don't always share the understanding of what devolution is for. You must start with all partners, including the community, agreeing a shared vision that needs to change to achieve it. Otherwise, there won't be the commitment to carry through changes. In the wake of COVID-19, we're reviewing all of our policies. I'll be also looking at the future of health devolution in the context of the impact of COVID-19 has had and continue to have on local government and the NHS. Turning to your first question about the purpose and powers of health and wellbeing boards, the added value of health and wellbeing boards is important to us. The LGA published research last year which looked at a sample of 22, which are making good progress integrating health and care, improving health and wellbeing, and tackling the wider determinants of health to identify their unique contribution. We have some examples. For instance, Coventry and Warwickshire Health and Wellbeing Boards have an alliance concordat that describes how partners will collaborate in a place-based approach covering the ICS level. There have been other major drivers of change. For example, in Wigan, the Health and Wellbeing Board has brought the whole health and care budgets together, either in Section 75 or pool or aligned budgets, which also include housing and leisure. We've got numerous examples of health and wellbeing boards driven in all policies and asset-based approaches to health and wellbeing. Nottinghamshire and East Riding and Bath have driven forward at pace place-based neighbourhood approaches on healthy food and health in planning and community resilience. They're also highly effective strategic planning vehicles because they have a knowledge and reach into their community. This is a really powerful asset when combined with the population health data. In Chester West and Chester, they have a series of community conversations with over 500 residents in 49 venues, plus phone and online arrangements. The involvement of health and wellbeing boards in ICS and STPs is improving, but still variable. Where it's good, it's helped the system to understand and adapt to strategic plans to the needs of the different places within. For instance, West Yorkshire have works in 6 individual places, localities, and only unless there's a compelling reason does it go to a system level. Across the country, health and wellbeing boards have been effective in building shared leadership by politicians, clinicians, and community representatives, which is central to devolution. We have the case studies of the 22 health and wellbeing boards on our website, and I'm happy to share those details with you. The relationship between the centre and local is very different in the NHS and government. Despite the movement to system by default and the growing importance of STPs and APSs, the NHS is still nationally led and run, very much top-down command and control. Accountability for achieving the objectives of the NHS long-term plan is upwards to the Secretary of State. By contrast, councils of leaders of place are first and foremost accountable to their residents for the outcomes they achieve. The government and national bodies need to give local NHS, council and community leaders the space, authority, sufficient resources and trust to take the decisions as close as possible to and in partnership with the communities they're affecting. This means getting rid of some of the national targets, which may have little relevance at a local level. National targets undermine existing place-based activity. For instance, national targets on recruiting 1,000 social prescribing link workers by April 2020 sounds compelling, but if it's taking away the local roles for people to go to the NHS, we have a void in the workforce. Finally, COVID-19 has shaken our world, and it will take time for the dust to settle to see clearly where the lessons are. Though we are past the peak in hospitals and care homes, we're still supporting millions of shielded and vulnerable people. So we need to be careful about jumping to conclusions. But some things are emerging. Centralized control and delivery has been beset with problems. Examples include the national procurement and supply of PPE, centralized testing, identification of shielded cohort, problems with data sharing, and provision of food and other support to shielded vulnerable people. This is because there's no national response for addressing the challenges which manifest themselves in different ways in different places and don't have regard to existing local communities. It's also about different social and economic factors which vary hugely across the country. And there's really concerning findings about the BAME communities being so badly affected by COVID-19, making it particularly important to have local approaches and local community. Local government can get the job done effectively more than national coordination. We're not saying there is no place for national incentives and programs, but we need to build from the bottom up and provide local political leaders with the resources, flexibilities to develop their own solutions in the first instance. They are most fleet of foot, more in tune with local intelligence, and have the connections with their communities and partners to communicate what has been done. Thank you.
Ian, you get the gold star for performing to time. That's very impressive. Thank you very much. And very powerful and clear. And I particularly like the local case studies that you showcased, as it were. Perhaps I could just start with a quick question for me, and then I'll open it up to others. If you could show if you want to ask a question. I'm interested in, you talked about the health and wellbeing boards, but what about the ICSs as well? Do you see that routinely local authorities are getting a clear enough voice, and are you being recognised, and social care and the other services being recognised sufficiently within ICSs for the contribution you can make to the health and well-being of your communities?
I certainly think there's an understanding, and it's probably changed dramatically over the last few months with the way social care has actually become such an integral part. But there's always been that working at the ICS level, there's always been that understanding about social care. But because of the command and control nature of the NHS, it's been difficult for NHS to really understand what it means locally. I think now with what's happened with COVID and the fact that teams across the country have just simply sort of merged into one, and NHS and local government are just developing those strategies well, working together. There's a better understanding, and what we've got to make sure is when we come out of this, that everybody recognises the important role social care has played in this, because of course making sure that, and you know, it is a contentious subject, of course, creating the space of 30,000 beds in hospitals that weren't there at the start was really important to make sure they had the capacity to deliver the care.
Thank you. Now, can I invite contributions from other commissioners, please? Because frustratingly on my iPhone, I can't see more than 3 other people. I need to be told who it is who has their hands up. So can I have, now I see a hand up there.
Alistair's after a question.
So Alistair first.
Thanks, Norman. And I know from my chat that Stephen has a question as well. Thanks, Ian. I just wanted to ask about a familiar question. You talk about national targets going because they don't always have local relevance. How then, in that system, do you deal with the charge that national targets are there to improve performance and raise the standards for everyone? And if the target is different in Wigan from Manchester, say, what stops political parties exploiting that and saying, why isn't our performance good enough? And it's not a good enough answer to say, well, our local target is lower than it is somewhere else. Doesn't the national target ensure that things are constantly pushed to the best, and you avoid the charge of postcode lottery if one set of targets are seen to be lower than another? And just saying it's different local need doesn't always avoid a local political charge that we're not doing as well as our neighbour.
I understand exactly where you're coming from. If it's the same outcome that people are looking for, and with different targets, you can be accused of that. But of course, you've got to take into account local understandings and local needs. Even within towns, we know there's areas where different communities have different outcomes and different determinants of health. And I think it's important we actually use that information at the super ward output level to make sure we get the best for those communities, because where you have a life expectancy of 15 years between 2 communities that are living 4 years apart, I think we've got to understand that just simply having one target for both of them isn't providing the best health outcomes for those communities. We've got to drill down and make sure that people understand the reasons why there's the different targets.
Thank you. Stephen next, please. And I think Sean had his hand up as well.
Yeah, that's right.
Ian, thank you for your introduction, which I agree with Norman's summary of it. But I think the question I put in the chat seems to me to be the central challenge for those of us who want to argue the case for a more localized health, social care, a broader public service structure. We have to face the fact that some of the worst outcomes over the last couple of months have arisen in the social care system as people have been discharged out of hospital without proper safeguards, as there hasn't been proper supplies of PPE, availability of staff, and so on and so forth. I think that's now, frankly, pretty well documented. And there seems to me to be a very serious risk that the policy response to that will be argued that what we should be doing is therefore greater centralization, greater control, in order not just to apply standards, as Alistair says, but actually to apply management in order to ensure that we don't get the kind of issues, we live with the kind of issues we've experienced during COVID. Now, personally, we're on the Devolution Commission. Secret is in the name. I think that would be the wrong response. But I think we should be very clear that there's a serious danger, I think, of the public argument going in that direction. And my question to you really is, how is the LGA, how do you think local government in general should position itself to prepare for that argument, respond to it, and ensure that the argument for devolution isn't lost in the conclusions of what went wrong in COVID.
And Ian, can you keep your response quite succinct? Because I know I've got 2 other people to bring in and we've got to move on in about 4 minutes.
Okay, no problem. I mean, the answer to that is have parity with the NHS. The reason that we've had the issues is because the PPE has been targeted to the NHS, which meant there was a void for social care, and social care was having difficulties because even in mid-flight from China, consignments of PPE was sequestered by the NHS that should have gone to social care. So if we have parity with NHS and social care, that problem should resolve itself. Also resources, £13 billion was written off for the NHS. Local governments are expecting a £10 billion shortfall this year. If we don't receive that additional funding from central government, we'll have to find the money from somewhere else because we deliver balanced budgets every year.
That's very succinct. Thank you, Ian. Now, Sean and Alistair, I think, want to ask questions. Can you both keep your questions succinct so that we can keep to time?
Will do. Thank you, Norman. Thanks very much, Ian. Quick question really is, I'm quite interested in your reflections on the future of public health funding and the public health grant, which is obviously core to delivering the local services that you drive, both for Oxfordshire, but also in your role at the LGA, and whether COVID now will allow for a more considered argument about the role of supporting public health funding for things like smoking cessation or well-being, all those things that we know build community resilience against a pandemic such that we're experiencing right now.
And I'm going to bring Alistair in, and you can respond, Ian, to both of them if that's okay. So, Alistair.
No, you're not. I asked my question, Norman. I didn't have another.
Oh, sorry. Is it right? Okay. I thought it could come up again. I do apologise. So, Ian, over to you.
Okay, when public health was returned to local government back in 2013, we took it over and we were very pleased to. Since then, the budget has been cut by about £700 million, whereas the NHS budgets have increased by the same tune. Yet, out of the 120 key factors that we're tested against, 80 have remained the same or improved. So local governments have shown we can do well with limited budgets, and particularly in public health, because of course the main thing is we're linking it to everything in planning, place, leisure, and we can really deliver there. Thank you.
I think you've shown a discipline in local government that isn't always present in the NHS, but thank you very much indeed. Ian. Do stay if you're able to for the general discussion. And can I now bring in Dr. Tom Coffey, London Mayor's Senior Health Advisor, but I do understand, Tom, that you're giving personal reflections rather than in your policy role for the Mayor, but over to you. And if you could keep it again to 7 minutes, that would be great.
I'm a GP, everything's done in 7 minutes, no problem.
Yeah, very good. Over to you.
So therefore, I'll talk very much about devolution from a London perspective, and very much about national to regional and NHS to a local authority and local government. We had a memorandum of understanding a few years ago, and I don't think it's delivered what we thought it would deliver. We covered a number of areas, but in fact, what probably transpired over a few years was the majority of benefits occurred because of partnership working and not because of new delegated powers. And if anything, some of the promises of delegated powers, when it didn't happen, if anything, sabotaged relationships. The example I would give was that there was a great hope the transformation funding of the NHS will be devolved and used collectively. That did not happen for various, clear reasons, but that really did undermine the relationship at the outset. However, the partnerships which did develop probably delivered more than a devolution agreement in itself. What I wanted to talk about was, people said, what is good devolution? And in essence, in the experience that we've had in London, good devolution occurs when you've got clear delegation of finances or clear delegation of legal powers. Otherwise, we're really talking about improved partnership working and using existing powers. The two areas where we've shown some progress has been in the areas where that's occurred. And I'll give you two examples, one on estates and one on workforce. So for estates, we were given the ability to, on a London basis, have a London-wide collective business case approval system. So no longer would it be the NHS on its own approving its business cases. We formed the London Estates Board. The London Estates Board had the GLA, NHS, local authorities on it, and we could decide collectively the way we would spend the NHS money. Also, the NHS gets a capital yearly approval system, and that money was allocated. Again, the London Estates Board had oversight and approval of that. However, the foundation trusts were able to use their money as they wish, and that wasn't part of the LEB. We did manage to get a London Estates delivery unit, which actually used some of the operational skills in City Hall to assist the NHS to be much more rapid and focused in their estates planning. And that was an example of partnership working. The area where perhaps we didn't work, we would like to, was where primary care estate and the local authority, the benefits there whereby the local authorities are much better at developing GP premises than NHS are. That was offered a number of times by local authority, but probably wasn't fully grasped by the NHS. Equally, what was very clear, and we've asked for again and again, is a 10-year capital allocation for all devolved areas. Every large hospital is at least 5 years from planning to putting a shovel in the ground and getting the building open. To base your planning for capital on yearly allocation is absolutely daft. And so the clear ask for all devolved authorities for good devolution would be, as a minimum, a 10-year NHS capital allocation to plan properly. On workforce, there was again a devolution of the education transformation money, which did allow us to do some local work like London Capital Nursing Campaign. But the only way it would work more effectively if the training budget or the education budget was devolved wholly to London, recognizing London is an exporter of doctors and nurses. However, if you don't get that level of devolution, you're just doing partnership working and not proper devolution. I was asked about how the mayor does his what's called his Civic 6 tests. So we used our partnership working to look at how we assess reconfigurations in the NHS. So this is a mayor who doesn't have any oversight or scrutiny powers, developing a process with the King's Fund and developing 6 tests to measure what would be good for London: beds, money, social care, clinical engagement, public engagement, and health inequality. And Sadiq used those 6 tests against reconfigurations. We do it with an outside independent agency like the King's Fund or the Nuffield. And that gives us a way as a mayor to have oversight and scrutiny of healthcare reconfigurations. This is often supported by the local authority, who've often been very wary that they've been invited late to the table on consultations. The reason it's worked quite well is now the NHS, being very aware we're going to do this, in fact, give submissions to us in advance of their consultation, because they know if they don't comply or try to comply with the 6 tests, the political approval will not be there. And we've done that a number of times now, and we've found it's worked very effectively. But again, it's an example of partnership working and not a devolved power. On public health, I think we're probably a bit surprised how much Sadiq and the mayor can do on public health. And Sadiq has clearly adopted the idea of, as a devolved mayor, of health in all policies. Examples being that for childhood obesity, we have the heaviest children in the country, and our poorest children are the heaviest in London. And therefore, the mayor has been very clearly to have a new planning law. No new fast food shops within 400 metres of a school. We've passed that in our planning rules, and that now is part of the agreement for London. Secondly, we control TfL, and there's now no fast food advertising on a TfL estate, again, to reduce childhood obesity. When we do our transport policy, again, as a devolved authority, and health and all policies. The transport is about walking and cycling, not buses and tubes. And very clearly, we will use our powers to improve the health of London. And I think we were the first people, I would argue, who saw violent crime as a public health emergency and was very clear early on to say, this is not about a criminal justice system, this is about a public health approach. And we're investing many millions in our public health system, in our early years system, to address the causes of violent crime, rather than the prevention of crime after it's happened. However, again, our public health approach will be strengthened by clear delegation of financial budgets, perhaps a citywide public health budget, which would assist us, or clear extension of legal powers on licensing, on gambling, on the raising of taxes from sugar taxes. So again, I would say that devolution can be very effective, but if it doesn't come with teeth, you're really working on partnership working alone. Thank you.
Blimey, we've had 2 witnesses who stuck to time. This is extraordinary. Thank you very much indeed, Tom. Really interesting. Again, if I could just start with a question. I'm conscious that within the ICSs, in a way, it's very much a sort of coalition of the willing, that there's no power to impose joint working or collaboration, integration on the part of anyone. You have to take people with you. If we could imagine a sort of really effective decentralized health and care system, would you want that arrangement to be maintained on the basis that actually persuading and taking people with you is ultimately the best approach? Or do you think there needs to be some mechanism for someone or some body to drive better integration, better prevention, and so forth? So I'd be interested in your response to that.
I mean, probably the latter. I think that at the moment, the willing are the people who are kind of coming to the table. My sense is that you need a much more clearer governance structure and accountability agreement, because eventually we'll be moving into territory whereby reconfigurations might happen, difficult decisions will be made. And my sense is that without a clear accountability agreement of all partners, I think the ICSs could disintegrate. When you get decisions regarding hospital changes or financial changes without clear accountability agreements with a legal basis, I think it will struggle to progress. In London, we have the London Health Board, which the mayor chairs, and the head of the NHS, 5 local authority leaders, are present, and that gives very much a coalition of the willing approach to improving health for Londoners. But my sense is for the ICSs, they'll need a stronger accountability agreement.
Thank you very much indeed. So we've got until about 3:52 for questions and answers in this section. I see on the chat that Warren and Stephen have written comments or questions. Do either of you want to come in to pose a question to Tom? Warren?
Could I? Well, Warren, go first if you wish to.
Warren first?
No question from me.
You're okay. Okay, Stephen.
Could I pick up your question and take it a slightly different direction, Norman? Because you asked, is it the choice between sort of regulatory action through ICSs or the coalition of the willing? The way that it seems to me there's an opportunity, which I've put in the chat, is to use digital infrastructure to create a series of benign incentives to make it easy for people to do the right thing. You can't, it seems to me, in the modern world, have properly joined up services at a local level unless you've got a single joined up digital infrastructure to support those integrated services. And one of the routes that seems to me to be we should look at is making it a joint responsibility rather than something the NHS does or local government does on their side of the silo. You actually make it a joint responsibility of local government, and the NHS to build the infrastructure that will underwrite successful delivery of integrated services. I'd be interested in Tom's views about that.
Yeah. I would have to agree, because whenever we've tried to do integration, and this is even with a GP practice and a hospital, the biggest barrier is the sharing of the record. Equally, when we do a similar work with a local authority, again, it's record sharing. And without the patient record being shared across services, it's very hard to integrate service and make them more streamlined. So a requirement for the integration of the patient record, which very much is part of the digital system now, my sense will be a bit of a Trojan horse probably to create a better integrated service, because it definitely is the obstacle of the last 10 years for better integration.
Really interesting, thank you. Can I have other contributions, please? And whoever comes next, can you make sure that you keep your question succinct so that we've got time to get through a few in the next 5 minutes? Other
Norman, can I come in? It's Phil.
Yes, who's that?
It's Phil Hope.
Yeah, Phil.
Yeah, Tom, could you just say, really helpful, thank you. One of the other barriers that we've been struggling with is this knotty question of geographical footprints. You think about what Manchester covers, Greater Manchester, with a number of boroughs and ICSs embedded within it, and they've set up various structures for that, some of which are just at the edges of kind of what's legal, I guess, but it works. In London, it's similarly very large geographical footprint for the mayor. ICS is a different geographical footprint. You've got, I don't know how many London boroughs there are. If we're going to do health devolution, to what extent is that simply a matter of, you know, coming up with some sensible, pragmatic answers to where power lies at different levels and so on? And how much do you think it could be a real barrier to people structurally being able to have integrated budgets, integrated records, integrated public health programs and so on? The footprint question.
Okay, so the two principles which we've applied, which may answer your question partially, is first the idea of subsidiarity. Therefore, wherever possible, the natural boundary we use for integration is the borough. Because yeah, you ask any patient, you know, I don't live in north central London, I live in Barnet or Wandsworth or Tooting. And so therefore, when you're trying to work out integration, that's what one should do. Next thing, principle we say is, are there any things that should be done better once for London? And I have to say, they are often the digital solutions, to say, it's pointless repeating the same governance issue or issues regarding communication. They're done best once for London. So in fact, when you divide much of what you're doing, you in fact find most migrate to the top or sink to the bottom. And in fact, the ICS, which is a bit in the middle, is often left with just hospital reconfiguration type issues, whilst in fact, most actual big service change happens in the city or the borough.
So, and do you think that the emergence of the ICS as the sort of chosen delivery level rather jars with that? And do you think the ICSs across London understand that actually the borough level will often be the appropriate level to do it, if not the whole of London?
Yes, I think partially. So having seen some of the STP plans, a lot of them do make that clear statement that they want to work very borough-based. So if you're doing reforming in areas like children's services, mental health, primary care, learning difficulties, where your key partner is your local authority, therefore the key area of integration and footprint should be your local authority in your borough. When you're looking at, say, reconfiguration of cancer services, cardiac services, where in fact it's a much larger system, it's probably best done ICS or London-wide. So I think you'll find the services themselves naturally choose the footprint of integration that is best for them.
That's really helpful. Thank you. Other contributions? We've got another couple of minutes. Silence. This is your opportunity.
Yeah, I've got a question. Sophie Corlett here.
Sophie.
Hi there. You're talking about you know, borough, London-wide, and then not much for ICS, but nevertheless ICS in the middle. How do you think for
We've lost you.
Sophie, you got mute.
Sophie, we've lost your sound.
Can you recover your sound, Sophie? Anyone else want to make a quick comment? Put anything to Tom?
I've got one more, if I could ask another one, if nobody else wants to.
Go on, in you go.
Yeah, sorry. So, Tom, it's about the relationships between the civic leadership and the clinical leadership within and across London. We know there's the structural questions, legal powers and so on, but a lot of it comes down to personal relationships. And some of the experience that we've heard about has been that the clinical leadership has been not as forthcoming, not as generous, not as in a sharing spirit, maybe, particularly from the acute, as with other parts of the system. I don't know if that's your experience in London, or if you've got other experiences about that real civic leadership, clinical leadership relationship.
Okay,
Keep your response very succinct, Tom.
So again, the civic leaders that we tend to relate to are local authority elected leaders, and obviously the mayor London-wide. And the GPs, who are very much community-based, tend to be the key clinical colleagues they relate to. The medical directors and the hospital consultants tend to look inwards to the NHS because that's their power base. So I would be pushing, and Sam Everington, a local GP, is very clear that the CCG chairs, the GPs, are the mini mayors of the borough who want to work with their local authority elected colleagues, and that's where I'd put your effort.
Very, very succinct. Thank you. Now, Sophie, I know she had computer problems.
Yeah, my computer does that every now and then. It obviously thinks I talk too much and just turns me off.
Very succinct, Sophie.
Yes, very succinct. It's because of the multi-layers, particularly in London. How easy is it for users and the public to get involved? Because they've got to get, there's their local GP practice, there's the local level of the borough, there's pan-London things that are relevant for some conditions or some services. How difficult is that really to negotiate? Do you get effectively professionalised public members?
Very important question. Thank you, Sophie.
Yes, I think you do a bit. And again, we tend to find people are very interested when there's a survey, when something's happening. They want to get, that your patients and public want to get involved regarding a service change. Otherwise, again, it's very much the professional service voice from the Alzheimer's Society, etc. Again, the ICSs are making pretty impressive efforts to engage them, but patients naturally go to the people they recognise personally, which is their hospital, their GP, their social care provider, and it tends to be that way rather than the larger footprints that we tend to operate on.
Thank you very much indeed, Tom. Great to have your contribution. Do stay if you can to engage in the discussion. Can I now introduce John Resdell, Chief Executive of Managers in Partnership. John, you've got 7 minutes from now.
Thank you, and I'm wasting time to unmute myself. And I'm, as someone who's paid to talk a lot of hot air for long periods of time, I'm going to struggle with this challenge. But and also, we've been banned from using Zoom in my organisation, so the fact I'm on this call just shows you I'm the Dominic Cummings of the trade union movement. I just wanted to sort of use my 7 minutes to talk about the response of our members to the pandemic and what that might then tell us about the future of health and healthcare. Identify the gaps that they feel have been exposed more obviously and in some cases brutally by the pandemic, and then sort of end with the sort of 3 key themes that keep coming through all the conversations we have with our members about what they'd like to see in the next sort of development of reform. And we do all of this from the vantage point of being a trade union for 6,000 predominantly NHS managers, but also care managers as well. So I'd just like to start by, the amazing response that we've seen from health and care workers, should give us, some cause for hope. And we've had people working incredibly hard and having many of them been through a sort of emotional and physical wringer in the last 2 months, the impact of which is going to be very long lasting. But I think the contribution of public servants in many sectors has been absolutely exceptional. And I'm thinking about managers in particular. They've obviously done a job of refocusing services to tackle a pandemic. A pandemic we don't fully understand in every regard, and it's making it up as we go along. They've taken opportunities to accelerate change and to learn things. Yesterday I did a urology outpatient appointment online, a very interesting experience, but clearly things that have taken years to get off the ground have all been done within weeks. We have seen the development at speed of sort of mutual aid to other sectors, particularly social care, which a lot of our members have been both, valued and seen the importance of, but actually learned a lot through doing. And now we're seeing people sort of preparing services to restart safely while maintaining the capacity to treat something that's going to be around for a long time. So, I think it's important that we acknowledge that what's been done has been quite exceptional, albeit with a sort of funding lack of constraint that you rarely come across in public sector service. So I think I'm really proud to represent my members at the best of times, but I'm, much prouder now than ever before. In the conversations we've had, obviously people are up to their necks in the pandemic, but the things they're learning have also made them quite thoughtful about the future. And I think what most members are asking at all levels, and I think this is probably a broader question, is have we reached a point of genuine moment of reform change, or has we just been shocked into sort of temporary cessation of business as usual? And I think it's a key theme that comes out of all the conversations we've had. I mean, members would want to capture a lot of what has changed, but they're dubious about, once things have moved on, that we'll be able to do that. So what I'm going to offer is some of the things that people have said in the last month or so through the prism of the things the Commission, I think, is usefully been distinguishing, the difference between health and healthcare, which I think is quite an important distinction to keep making because people smash them together, and also the sort of the difference, albeit related, issues of devolution and integration. So I think the gaps that people are talking about, I mean, generally speaking, and I think, we've sort of been so stuck in managing the crisis itself, we haven't been saying it that strongly as a union, but we will start to, is this perception that the public realm, in all aspects has sort of not been funded and prepared and strategic enough to deal with what has happened. And I, strongly support let's look at what other countries have done. The fact that only today we are launching test and trace, local government wasn't called on for months, really, in any meaningful way to deal with those issues. But also the fact that the pandemic, the reality of it is it's being borne by the people with the fewest social and economic resources. So that sense that, public realm has been hollowed out too much, and that has been exposed by the pandemic, I think is very strong amongst our members. Secondly, I think is the brutal exposure of our failure to invest in social care. So you see the differences in structure and resources, and frankly, political and policy attention to the needs of people who are either working in social care or obviously being cared for there. I think someone in the comment mentioned who on stage has responsibility or expertise around the area. It's a very telling point. And interestingly, given who most of my members are, there is starting to question the validity of the ring fence of healthcare spending that we have seen for the last 10 or so years. So I think that for us is a major gap. And then finally, within healthcare, we still see the relative disadvantages of services outside hospitals. I think within this pandemic response, we've seen a huge centralisation of control. NHS England have basically taken over services for the duration. A lot of this has been going on, and it probably was before the pandemic, but without a lot of formal governance or the structures to support some of the decisions that are being taken. And from a sort of civic point, issue, I think a lot of the changes that we are we've made temporarily at speed, many of which are very, exciting and potentially beneficial, have mostly been done without any consultation with public and service users. So if we are going to lock in some of these benefits as they emerge, then we've got to rethink how we then consult to do that permanently. So a lot of temporary change may be beneficial, but it still needs to be processed through consultation. So those are some of the big gaps that I think members have been raising with us in the last 4 to 6 weeks. So ending with sort of 3 broad recommendations to you as a Commission, things we think need to be seen in any reports from the Commission, themes from our members. I mean, the first thing is that there has to be a central recommendation around social care, and that any further devolution that doesn't address all the issues that we've seen around funding, resources and policy around social care will make it just half a job. It will not be the successful reform that I think our members are certainly signalling they want to see. I think some of the things we have seen by way of mutual aid, joint working, supporting some of the smaller care homes with training, infection control, all of that stuff is great. But if it could potentially lead to some more structural support between the sectors, I think that would be good. But without the funding, I think someone used the word parity, I think we're going to struggle to really achieve that.
Could you just reference your final 2, John?
And then the second one is we do need a management resource, and it needs to be within a framework of accountability and governance. More and more people are concerned about the lack of that at the moment, and whilst crisis and goodwill can take you so far, ultimately it is not going to make for long-term change. And finally, a really important point, particularly given what Marmot was saying to us at one of the earlier sessions, the workforce of health and care is potentially an important part of the wider determinants of healthcare in an economy, in that it provides jobs and employment and social mobility, and we'd like to see that reflected in the Commission's final report.
Thank you very much indeed, John. Thank you. So we've got 10 minutes now for questions. I'm going to offer a self-denying ordinance and invite other commissioners who haven't yet asked any questions the first opportunity to ask a question of John.
Linda's here. Yes, can I ask something?
Linda.
It's really what you were saying about, we keep talking about social care, and of course the prominence of the care home crisis is actually a problem of predominantly the private sector, because care homes are actually mainly privately run. There's very few under local authority control anymore, a few non-for-profit. Most of them are for profit. Now 50% are publicly funded in terms of the residents getting support, but 50% are self-funded. 400,000 people living across the country in care homes, and we've seen the desperate need for better support as you talk about training, workforce, PPE, the whole lot.
Yeah.
And I think it's really exposed the crisis. But I think we need to be careful on the Commission that when we talk about social care, that we do include the care homes, but actually obviously acknowledge that they are not the old-fashioned way of thinking about local authority provision, because it just is not. And I'm sure some of your members are actually working in the private sector.
Yeah, they are. I think that's an important point. I mean, one thing, particularly say to PPE, the difference between having 200 or so NHS organisations versus sort of 15,000 care homes in sort of planning, logistics, engagement, intelligence sharing, I think, has become really marked. And how you deal with that, it probably must require some kind of devolved settlement to allow the degree of conversation with, those fragmented kind of organisation. And the variation within the 15,000, some of the bigger chains obviously have more resources to deploy at a time like this. Others are really stretched. It still goes back to funding, whether it's a public, private, bigger blocks or not. The reality is the funding differences between, say, healthcare and social care would still need to be closed. And I think that's the message from most of our members.
I think I saw Ian probably nodding at some of those comments. Thank you for that. Other contributions, please. Anyone who hasn't yet raised anything who wants to speak now? No. Well, anyone who has raised questions, please come in.
Yeah, this is Phil again. John, in the past, you've talked about some anxiety among clinical managers in the NHS, worrying about, as it were, civic leaders making decisions that could be bordering on the clinical territory, as it were, and how that works. Can you say what those relationships have been like during the COVID experience, and whether those anxieties have got worsened and heightened, and people are anxious about, you know, the role of chief executives of local authorities or even councillors in making or influencing clinical decisions, or whether or not, you know, which way has that gone, or how has it felt during the last few months?
I think, I mean, from what I'm picking up, most people have had a positive experience, because most people have kind of set aside, you know, normal business, normal relationships, normal anxieties to get on with things. And, you know, I suppose the question I was posing is has that been a big enough experience to continue beyond this, or will the old sort of fears and relationships just reassert themselves? And, you know, that probably is a question for the Commission to answer. I mean, I still think that anxiety exists. I mean, I remember talking to someone who was a then PCT clinical leader in dentistry, who, you know, witnessed a fist fight at a council meeting about where a new practice should be cited. And this for them wasn't really how decision making should roll. And I think that's obviously an extreme example, but the interplay of local politics with clinical decision making or configuration, I think, is something that at the moment it kind of gets channeled in formal consultations. There isn't quite the oversight or power to direct that, you know, might exist under that more devolved setting. I still think longer term that will be one of the key issues to address if you're going to get, you know, buy-in from you know, the professional groups within healthcare, and arguably some of the more sort of strategic business managers as well.
John, on that point, I guess, where do you think sentiment lies amongst your membership for, you know, in terms of appetite for a much more devolved system of health and social care provision? Social care is already devolved, but health provision in particular.
I think in normal conditions, I think people are still very, you know, supportive of greater devolved power. I think obviously the relationship of what are you devolving? You're devolving within healthcare, or you're devolving health and healthcare to a sort of combined oversight body. I still think that's an issue. But I mean, culture is really strong, and the one thing that everyone has relied on in the last 2 months is very strong central messages from leaders up there. And I wonder whether, you know, one of the things to unpick in a few months' time is, you know, how much of that is actually essential to get through the crisis, or how much of it is simply the habit of, you know, 20, 30-year careers where, you know, when things are really on, then, you know, everyone looks up to get money, get solutions, get instructions.
Thank you, Stephen.
Yeah, it's more precise than that, John, isn't it? Within the NHS, they look up because that's where their next career comes from, move comes from. Yeah. My question was taking you back to what you said about money, because I'm absolutely certain that one of the major things that's encouraged change behaviour during the COVID crisis is simply the fact that the spending controls have been lifted effectively within the NHS. And that's meant that people find it easier to work together than they previously did, because they didn't have to defend NHS budgets. Now, clearly that can't go on indefinitely. So, and you've rightly said, I agree with you, that part of the answer has to be a more equitable financial settlement from the local government perspective. I wonder if you could say anything more. Do you have anything more tangible that you think that we should consider about what future financing should look like in order to deliver a better outcome?
I suppose, well, I don't think I do have the funding mechanism to hand. I think what I think we're signalling is that the ring fence around health needs to now be widened to a much broader set of services, including social care. I think people are concerned that, you know, some of the gains of the last couple of months, including better working relationships, will be lost when scrutiny and funding becomes constrained again. And indeed, you know, some of our members are now quite concerned about how the decisions they have been making in this period of largesse, relative speaking, will be, you know, retrospectively questioned and assessed. So I think that, you know, my concern is we probably, you know, we'll go back sooner than we'd like to sort of old ways of thinking and working, partly because the money will change in the normal direction, and also the sense that this you know, all the money that has been spent has to come back out at some point in the future.
Now we've got about a minute left before we bring in Christina. Any final comment or question to John?
Yeah, it was really just to follow. It's Alistair Burt. It's just to follow up Stephen's question, because if I'm wondering how NHS managers will cope with a change funding system where they will see money that was previously theirs moving in another direction, as Stephen indicated, and that poses a challenge for yourself and your colleagues as to how physically to manage that, and whether managers would then support and back devolution if that was one of the consequences.
Well, I think, John, I mean, I think this is the challenge for, you know, for managers in healthcare, and well, is what is it all for? Is if we have a joint responsibility for the health and care of our populations, then that should be driving some of the decisions that are taken. In a way, it's the same argument within healthcare now. When you talk to an acute trust chief executive about surrendering some of their money to improve community services or primary, that tension exists now. I think it's simply a new expression of something. You know, if we're serious about resource reallocation and integration, it's just extending the field of battle, isn't it, from where it is now.
Thank you, John, very much indeed. And can I now bring in Christina McAnee? I remember our last contact was probably when I was minister, so good to see and hear from you again. You've got 7 minutes, and then we'll have questions. Christina.
Thank you very much, Norman. Yeah, I'm sure it was. I think I was the trade union lead at that time for the NHS trade unions.
That's right.
Yeah, thank you for this, for the opportunity to speak to you. I think what I wanted to do was just give something about, if you like, I suppose, what the impact of the pandemic and COVID-19 has meant in terms of my union's response and our views on perhaps the landscape that is out there at the moment in terms of health and social care and the whole devolution debate. And just to give some context for those who don't know, we're the biggest trade union in the country, we're the biggest public sector union, and we're the main union for staff who work in local government, health and social care. So we have about over 400,000 staff working in the NHS. This is UK-wide. We have, I've just got the figures today, 185,000 members who work in social care, and on top of that there's about another 450 to 500,000 who work in local government and schools. That's a kind of combination, and we have members doing other things as well. But so that's just to give you a flavour of where we're coming from. And I think what the key thing that's happened in terms of our experience over the past couple of months has demonstrated without any doubt the differences between health and social care. It's become starkly apparent, and it also, I suppose, has made us question the effectiveness of some of the policies that have been around for some time now around integration of health and social care. And I think things around like the integrated care systems, how effective have they been in when you're faced with something like this pandemic? For all the fragmentation that exists within the NHS, it's still very much a national service, obviously, and at times of stress, it still seems to us that NHS England, Department for Health and Social Care, Secretary of State, politicians can to an extent direct resources and change practices within the sector to respond to a crisis to varying degrees. There's an infrastructure which makes that possible. There's a hierarchy of knowledge, expertise, responsibility and accountability within the NHS. And what's important to us is this is accompanied by a staffing structure which itself delivers things like national pay, national conditions, national training and a regulatory framework. There's a clear escalation route for dealing with issues as and when they arise. And there's a recognition running through the NHS. Now, again, variable levels of implementation of this, but there's a recognition that partnership working with trade unions is important and part of how you deliver things. And I think if you compare and contrast with what's happening in the care sector, and I take all the points that were made about local authorities, but they are very much the commissioners, not the providers of care. So therefore, they have a very different role when it comes to when you consider what happens in the NHS. And what we saw within the first few weeks of this was a huge escalation in terms of people coming to us for support and advice. We set up different hotlines for care workers, etc. Within 3 hours of setting one of them up, we had something like almost 4,000 inquiries from members on the ground. Over the last few weeks, when we've been looking to see where the main draw on our resources has been, about 90% of all the calls, emails, queries we've had have come from the social care sector. And I think that in itself tells a story in terms of what happens to the workforce in those areas, because they're coming to us directly as individuals, not necessarily going through any structures, because these structures don't exist. So I think what's happened is it's maybe made people question some of the issues around devolution in care and in health, and about whether it's actually something that can deliver in terms of some of the big issues that might face us in the future. What I think would be interesting to know, and this might be something that the Commission can do, it's certainly something we'll be looking at, is it'd be interesting to see some of the well-documented problems we've had in the care sector around access to PPE, the guidance that's going to them. I have no specific information on whether that's been better in areas where you've had good integrated models. So, for example, Greater Manchester. I saw one of the comments that had come in to say that they had an almost equalisation in terms of getting resources out to both care and health. And I think it would be an interesting piece of work to see whether that was replicated across the country where you have good integrated models at local level. I think it's important that we don't let this become something that says health or devolution is not a good thing. I think that point's been made by somebody else, but I think there's still an issue in terms of how people perceive the care sector in relation to the health service. It's not just all about structure, although that's probably fundamentally what it's about, but it's not all about that. Because if you look at things like, even if you look at the returning nurses, so I can't remember the figure, but thousands and thousands of nurses came back to the NHS, and I think fewer than 400 of them opted to work in the care sector. Again, this is about perception and how people see that sector. So I think for us, when we're looking forward to what does it mean in terms of how do you deliver good devolved services at health and social care, I think the key thing for us would be this has to be done in a framework, a national framework. So certainly when you're looking at a workforce perspective, this can't be done on a let a thousand flowers bloom, because we've tried it in other sectors, didn't work, hasn't delivered. So we're looking ourselves at some of the key things that we want to come out of this. And I think there is
got about another minute, Christine,
right,
if that's
I'll be
okay.
very quick. So I'll just end up with the three. I'll do what John said. I think mine are pretty similar to John's in terms of 3 key things that we would want out of this. One is a substantial funding boost across the sector, so sort of parity across sectors from local government, health and social care. And the other key one for us has to be a framework for staff. So there would have to be some proper workforce strategy that covers the entire workforce across health and social care, and leaving it up to the market, leaving it up to just the devolution forces and just integrated local services would not be enough to deliver the kind of staffing structure that we need to make proper delivery of fully joined up health and social care effective, and one that can actually adapt to the needs of local populations. That can't be done on a piecemeal basis, that has to be done on a national basis. So that's probably the key thing we would want to see the Commission looking at, is the workforce strategy. Thank you.
Thank you very much indeed, Christina. Perhaps I could just start by asking, I mean, if you felt that the sort of safeguards were in place that you've referred to, particularly around staff, and I guess that the current arrangement, without real devolved responsibility, has left staff in social care pretty vulnerable to varied treatment around the country. But if you felt that safeguards were in place, do you think your union would embrace the idea or the potential benefits that could be garnered from a more devolved health and social care system?
It would depend what you mean by safeguards, I think, Norman. I'm not quite sure safeguards would do it. I think we'd be looking for something more structural than just safeguards. I think it's fair to say that we're not opposed to and actually embrace the idea of more local accountability, more local determination of these kinds of services. Totally support that. But it's how it's done, how it's funded, and what would happen to the workforce. And we don't want to see local differences, if you like, you know, a kind of postcode lottery when it comes to paying conditions for the workforce. So there'd be strong resistance to that, I think.
But I guess that's what we've already got in social care, isn't it?
Oh yeah, absolutely.
Yeah. Okay, so thank you, Christina. Can I have, we've got another 8 minutes or so. Could I have questions from other commissioners? Who hasn't asked a question? Who was that?
It's Stephen.
Stephen, in you come.
Could I just come back to Christina on this point about the central-local balance and what works best for the staff, without whom, of course, none of these services can be delivered. It's worth reminding ourselves, isn't it, that the NHS is not always a model employer, and introducing something where there is more local engagement, more local accountability, ought to open the door for more flexible arrangements that work better for staff and actually make for the workplace to be a more rewarding, more professionally rewarding. The single model through the NHS isn't always the best employer.
I think in terms of looking across the public sector, it's one of the best employers, I would say. I wouldn't always tell that to NHS employers, but I think when you compare it to what happens in other sectors, it is one of the better employers, as in there is a structure there, there's a way of dealing with things that involves trade unions. You're right, it's not always perfect. Things go wrong at local level all the time. But by and large, these things are generally resolvable because there is a way to deal with it, which doesn't always exist in other sectors.
Yeah, I mean, if I may come back on that, what I mean by not always the best employer is that when you talk to staff, whether it's the medical staff, the nursing, other clinical staff, or indeed the non-clinical staff, it's quite often an issue about motivation, retention, job satisfaction, career prospects, and so forth. Those are all part of the employment package that a more localized system ought to be better placed to discuss. I mean, in my view, it should be, but do you think it could be better placed to deliver that kind of opportunity for career progression and service development?
Well, when we do staff surveys for our members who work in the NHS, some of the key things that come up that are off-putting to them are normally things like stress, workload. They always figure very highly. Pay doesn't always figure in the top two. It's usually 3 or 4. Pay will come into it, but it is things like stress and workload and I suppose feeling being in control of your work is very important to people. And that varies across the NHS. So there's huge variation across different parts of the country in terms of that. But by and large, they tend to come out quite well on job satisfaction is very high. People would recommend it as a career to go forward. So there's sort of quite swings and roundabouts when you look at some of the results that we get. And we do a huge staff survey, as does the NHS, of course, and pretty much reflects the things that we get as well. So because of those things, I'm not convinced that those are things that you could actually deal with any differently than they currently are, because, you know, they're all individual employers. And so again, you can pick out, you can see differences between different trusts and different health authorities as to how people view them. And a lot of that's to do with leadership in those particular areas.
Christina, I mean, one thing that I sometimes pick up is a sense, and I don't know how it comes up in your surveys, but a sense that sometimes you have a bit of a bullying culture within the NHS, and you hear stories about managers who feel obliged to drive central targets that have sort of been imposed from on high, then ends up sort of imposing unreasonable expectations on staff at a local level. And do you think that sort of command and control aspect of the NHS can sometimes be damaging to staff welfare, which could potentially feel more liberated if they felt more of a sense of accountability to their own communities?
It may well do in terms of building the bullying culture, because the area that comes out the worst by far in any surveys is always the ambulance service, which you could say is probably the strongest command and control approach to anything. So yeah, that obviously has its disadvantages, and I'm sure there's things you could do around that. But if we look at surveys that we do for our members in some other sectors, so for example, if you look at the social care and work that we've done there, the key things that come out there are not necessarily bullying or any of these things, but it is the sort of fundamental things around pay, conditions, lack of job security, lack of training. You know, those are the key things that come out in that sector. And you'd have to do that kind of balancing act, wouldn't you, about why people go in for a job and why they stay in a job. But then you look at turnover rates, it's much higher within care than it is within the NHS.
Mm. Thank you. Any final contributions?
Yeah, if possible. You know, I'm intrigued by the. I find this a difficult issue really, because you've got the kind of the NHS, which, as it were, holds all of its people in that kind of central way and described it with national terms and conditions, and then you've got hundreds of thousands of care workers scattered with no real sense of any commonality of pay and conditions and structures and frameworks. And I'm just thinking about devolution and the opportunity that integration brings at that local level for creating a kind of framework which allows for career progression, people to move between health and social care, for better paying conditions, proper training, apprenticeships that could move into up and down. And I don't know whether that's just a bit of a fantasy really, that possibly that kind of opportunity for that partnership between health and social care, really working with staff being the partners, as it were, working together and being able to value each other. I wear a hat as a trustee of a social care that provides both domiciliary and residential care, and where they've had nursing staff embedded in the social care system, it's so much better. The social care delivery is so much better, and I just wonder whether from your point of view, the opportunity is to really create structures for partnership working, but for staff, for workforce. Devolution offers that really any kind of national system simply can't.
Christina, can you keep your answer reasonably succinct, please?
Yeah, I think it would be difficult to have a structure where you've got one which is national, which is the NHS, and then try and, if you like, work alongside that with one which was very localised. Even if it was good in certain localities, I think there would be major difficulties, because you wouldn't be difficult to see how you would have standards going across both, because you could argue that the role of a healthcare assistant, the role of a care assistant within a care home are pretty similar in many ways. But if you don't have the same standards, you don't have the same training, you don't have the same regulation, then it's quite difficult to see how you could mesh the two of them together without some difficulty.
Thank you very much indeed. We probably now should move on to our final witness today. Last but not least, Harry Quilter Pinner, fellow at IPPR. Over to you, Harry.
Thanks, Norman. First of all, thank you for inviting me and IPPR to contribute to what is a really interesting discussion. So, as many of you will know, IPPR has been doing work on devolution now for over a decade. And I think of particular interest to the Commission is a programme that we ran in 2016 and 17 on health devolution specifically. And we asked 3 questions during that programme. 1, what is health devolution? 2, why do we want it? What's its potential benefits and also the risks associated? And where do we want to take it next? And so in my remarks today, what I'll do is briefly cover our answers to those 3 questions, and then also maybe just add at the end some thoughts on what's changed since then.
Right.
So I'm going to start with what it is, and I think everyone here probably knows, but I think it's worth being really explicit that you know, health devolution in this country, in England, is not devolution at all, but delegation. So Scotland has health devolution, has full accountability, and has full powers over health. Greater Manchester, which is the most advanced version of health devolution in England, is something much closer to delegation, where there have been some powers passed down, particularly budgets for certain things, but there's still a lot which is centralised, and we've heard that come through the conversation here quite a lot. It's still ultimately Simon Stevens and Matt Hancock who are legally in charge, even if Manchester and Greater Manchester is taking much more initiative in driving its own reform agenda locally. The second, and I'll come back to that because it's important, question 2 is why devolve? What do we think we're going to achieve by going for a kind of GM model, or going further than where we've gone in Greater Manchester? And IPPR's work, and I think the experience of Greater Manchester and other areas since then bears this out, is that there are 2 potential big benefits. And the first is about the type of change you can deliver in a local area. So in particular, I think the opportunity of devolution is to overcome the fragmentation, both the fragmentation of the Lansley reforms within health and social care, but also the fragmentation of public services beyond health and social care. And that's where the real opportunity is. You know, can you link up in the way that some people have discussed today, housing, welfare, transport policy with your health policy to really do prevention properly? That seems to me to be the big win out of health devolution, if you can get it right. And the second is about the pace of change. So regardless of what that change looks like, there is an opportunity with health devolution to speed up and catalyse change. And I think we identified 2 of the core mechanisms that might and is in some cases allowing that to happen. And one is about joining up or bringing leaders together at a local area, particularly in that gap that was filled by local health authorities, that kind of system management level, which GM have created. And the second is about simultaneously empowering those leaders to deliver change and also holding them accountable. And so I think one of the key themes that came out of our interviews and work with Greater Manchester was this kind of permission to innovate, that the default had turned from we have to ask NHS England unless otherwise stated to we'll get on with stuff unless otherwise stated. And that seems to me to be the big opportunity if we can get that right. We've then looked at, you know, and I think one of the big conclusions that came out of our research was if you want to get those benefits, you probably have to go further than we've gone in Greater Manchester. So you have to do health devolution properly. So there might be some benefits, and there clearly is, and I'm sure Warren would attest to that, to what we've done in Greater Manchester, but that there are even bigger potential benefits if you can go further. And IPPR set out a number of areas where you might want to go further on devolution. I won't go through them all here, but I will touch on 3 very briefly. One is on accountability, and Tom mentioned this earlier. which is that obviously at the moment accountability is still centralised. All of those organisations report up to the centre. We think there is an opportunity to drive bigger, bolder change if more of the accountability, so for example, accountability for trusts was linked to the combined authority, and that there was a greater role for the mayor in devolution in particular. So there's a point on accountability. The second is on funding, and that these 2 points are really linked, which is that whilst revenue raising and funding comes from the central government, there is always going to be a limit to how far you can go. We do not advocate at IPPR for complete fiscal devolution, particularly with regards to the NHS, but we do think that there are things that could be devolved, things like sin taxes and other areas where you could drive better health and also potentially raise revenue. And we also proposed passing at least half of the local NHS budget through the combined authority and local authorities. So it's a technocratic change, but what that would do is make local government an equal partner in that devolution settlement, because at the moment, most of the money still comes through NHS England. So could you pass half the budget through, for example, GM, and that would drive culture change and change power dynamics in the partnership. And the third is obviously there are big gaps in devolution in other bits of the public sector which limit how much you can achieve on that prevention side. So schooling, welfare, there's a whole load of other areas you might want to look at in terms of devolving powers to drive better prevention in an integrated local system. So before I finish, just two big changes since the work we did, that piece of work, both of which I'm going to kind of optimistically spin as where we might want to think about going in the future. And they're the two Ps, they are the politics and the pandemic. So first of all, the politics. Devolution in Greater Manchester came from a moment in time, and in particular it came from austerity and George Osborne. And that momentum, I think, has been lost since because of changes in personnel. I think there's an opportunity with this government, which has a very different electoral coalition, to change that. They've talked a lot about the levelling up agenda, but we need to persuade them that levelling up also means devolution, that you cannot level up, you cannot rebalance the regions without devolution. Point one. And point two is obviously the pandemic. We've talked about it a lot today. We've talked about the centralising tendencies that have happened or have been reignited during the pandemic. But I also think there's another story we can tell, which is one way you could read some of what's happened is that government couldn't micromanage every local area during this period. So they set a very clear mission, which was, we need to survive the pandemic, we need to save as many lives as possible. And then they took away some of the bureaucracy. They basically said, get on with it. And local areas, local leaders went and delivered that. So what we've seen is massive transformation, some of which we thought wasn't possible and we were told wasn't possible, something here, digital, for example, very, very quickly, partly because we let people get on with it and we gave them that permission to innovate, to achieve the central mission. That's a slightly optimistic take because there was centralising bits going on as well. But I think if we can investigate that hypothesis, speak to that narrative, we can maybe unlock some of the opportunities of devolution going forward.
Really, really interesting, Harry. And I do endorse your final comment that it's misleading just to say that power, command and control has been reinforced in this period in many ways, because it's been sort of crisis management. There has been greater autonomy, and I know this from experience as chair of the South London and Maudsley. There's been greater autonomy to get on and do things with less interference from the regulators, the national regulators. I was also struck by the point you made about permission to innovate, moving away from what I always call a sort of dependency culture, that you sort of wait for the centre to give you permission to do anything, and it usually doesn't come, so nothing much happens. My one question for you before I open it up to others is, you talked about not advocating total fiscal devolution. What did you say, if anything, about the power for localities to raise additional funds if they wish to for their health and social care system. If there's support locally for raising more money through taxation in the locality, because power resides ultimately where money is raised, it seems to me. Do you say anything about that in your report? And do you have any further sort of reflections since then on it?
So I should caveat my earlier remark with that we think fiscal devolution in general is a good thing and we've advocated for it. I think we think there is risk with starting with the NHS, basically, because it's probably the most national institution, if I can use those words. It's not, that we have, and therefore, so I think we're very positive about fiscal devolution. I think we ducked the question in the paper, if I'm honest, Norman, because of those political challenges. I think we posed the possibility that you could imagine a progressive mayor, like, for example, Andy Burnham, in a hypothetical future, saying, if you allowed us to raise income tax in the local area, for example, or a tax in the local area, and put it to the NHS, that they might do that. And I think there's something interesting in that. I guess it starts to really challenge, strike at the heart of what we think the N in the NHS means if you allow that to go too far. I think we'd rather see a proper funding settlement nationally, but that was devolved, was passed down in ways that gave local government an equal seat at the table. I think we would be nervous of significantly varying funding levels on the NHS across different areas.
Thank you very much. I've got Alistair wanting to speak. Can other people indicate also to me through the chat?
Yeah, Linda as well, yeah.
Okay, yeah. Alistair and then Linda.
Yeah, thanks, Harry. I had a couple of questions. One, do you have a view as to whether or not the argument on devolution has any bearing on the public-private financial split that we're going to see in the future? Anything that's going to be looking at health post COVID, particularly if it looks at systems abroad in Europe, is going to consider how private sector engagement in health and healthcare is handled. Do you think the devolution argument has anything to say about that? And do you have a particular view as to whether it opens up or closes down the argument for more private funding? And secondly, I was interested in the idea of local sin taxes. Does this mean I would pay more for my ice cream in Bury than I would do in Blackpool? And how do you handle sin taxes in a very local context? Slightly tongue-in-cheek, but worth thinking about. Thanks, Harry.
Great questions. Thanks, Alistair. So on your first point, I think that again, I'll be very nervous of any devolution settlement that devolved the ability to move to a fundamentally different funding system. I equally think that if we did devolve that power, very few local areas would use it, because I think what puts the N in NHS is not actually a set of national frameworks particularly, it's the fact that public believe it's a national service, want it to be a national service, and want it to be taxpayer funded. So I don't actually think that even if we said Manchester can go and introduce an insurance system, I don't think they would go. It would happen anyway. I think it might open up questions about provision, because I think if we achieve what we want to here, what we're trying to do is integrate a system where provision is mainly public on the NHS and provision is mainly private on social care. And so I think inherently you have to have if you want to make that work, you have to make those relationships work, and the NHS has to work with the private sector. So I think that's definitely one point to make. On sin taxes, yes, I think the implication of that is that you would have different costs in local areas. Certainly, you couldn't do it at a very, very local area. It would have to be at combined authority or kind of that kind of scale. But I think we've seen London, for example, call for similar powers, and I think they'd be worthwhile us investigating it.
We'll make sure we safeguard your ice creams around the country, Alistair.
Thanks, Jim. Very important things here.
Linda next, and then Phil. Keep it tight, please, both of you.
Yes, I just wondered if you thought there was any anything to be said about the power of the acute trusts within any devolved system, because it seems to me that that's the natural pull of the money. We know when money gets given, that's where it goes. It doesn't go to the other bits of service. So there could be an argument that says that the acute trusts are left to get on with whatever they do within their national framework, and the rest of the system can actually be delivered much more locally, such as community, GP, and all the place-based stuff we've talked about, the social care, but that you would ring fence the acute trusts in a way separately, because otherwise they're just going to take all the money, because we know that that's what happens. And I just wonder if there'd been any thinking on your part about that.
Succinct answer, please, Harry.
I agree with you that the acute trusts are a challenge here. That's why we advocated for changing of accountability, so they were accountable to the local area, because I think without that, you're not going to get proper place-based healthcare systems. I would actually be tempted to do it the other way around and basically give most of your budget to the community setting, and then if they fail to prevent people turning up at the acute trust gets a payment. So you basically bias the system but integrate it fundamentally. I don't think you can separate out acute trusts, but debate can go on.
Thank you. Next, Phil.
Yes, just briefly. My personal preference, as you know, is for a compulsory inheritance protection levy, i.e. that would raise enough money to fund a free social care system and protect people's inheritance, because they wouldn't lose their houses if they happen to get dementia. But putting that to one side, we do have already a locally based taxation system which is ring-fenced to support the social care system and the social care system alone. It's called the Social Care Council Tax Premium. Now, it does occur to me that we've got something in place that the government has always said it doesn't want, which is ring-fenced taxation for particular services. Could that be built on it? Could it be matched funded by central government, if you wanted to find the money to do so, as we come out of COVID-19, as being a simple and easy way to try and get a, if you like, locally driven income-raising measure based on some form of property tax, albeit a very aggressive one, as we know.
Harry, quick response.
I think we've said that if you want to fully fund the social care system properly, the revenue you'd need to raise is probably too large to do without a fundamental fiscal devolution settlement, which we might well want, but it is a separate question. And that the best way of doing it would be to fund social care in the same way that we fund the NHS out of national taxation. So I think there probably are some solutions at the local level, but they might not be the scale of solution needed to really get to grips with the scale of the social care crisis.
Harry, thank you very much indeed. Now, we could go on until 5. I have to leave promptly at 5 because I've got a phone call then. But we've got 12 more minutes, or 11, to discuss this. And I'm very keen to allow other witnesses today to give any thoughts that they might have on what they've heard during the course of the afternoon. So do please feel free, any of you, any of the witnesses, if you want to come in to make sort of final contributions in the time that we've got available to us. So who wants to come in first? You can't all go quiet on me, please.
Norman, it's Alison Morley here from the LGA, and really I just wanted to make a couple of final points on Ian's behalf, actually.
Yep.
In terms of devolution, and I was going to say that, so one of the things I think that has been really good with Greater Manchester is they have utterly embedded and tied their ambitions for health devolution with their wider devolution ambitions, and that is that you cannot have economic health without having physical health, and the burden of ill health on your economy has to be addressed. So I would say health devolution has to go hand in hand with wider devolution, because the best way to improve health and well-being outcomes is to address those wider determinants through better housing, education, jobs, giving children a better start in life, infrastructure, and actually looking at health devolution on its own will always therefore tend towards looking at health care and social care rather than getting better population health and well-being outcomes.
Thank you very much, Alison. Very important point, and very much mirrored what we were told by Michael Marmot in the first session back in the old world, before all the world changed in February, I think it was. So thank you for that. Other contributions, please. Yes, Sophie.
Yeah, I'd have liked to have asked Harry, but I think he's disappeared, or he's disappeared from my screen anyway, about if you are, I raised this last time, if you're going to devolve more of the budget, how do you ensure that areas choose to fund parts of the system that historically areas have not shown any enthusiasm for funding? So obviously I'm talking about mental health, but mental health is not the only one that areas have found they have needed some national sort of prompt to do, and pandemic awareness might be one of those.
The sort of drug and alcohol type of services.
Drug and alcohol, yeah. Yeah, smoking cessation, which, you know, local authorities have pulled out of, I mean, partly because they've got no money, but nevertheless, it's not been prioritised.
And I guess this again goes down to the balance to be struck in any system between what the centre can require and what is down to local discretion. And I mean, that, you know, within the current public health funding arrangements, my understanding is that there are some public health services that are core, that are required, others that are not, and the ones that are not have tended to lose out as public health has been cut back. Thankfully, I'm seeing nodding from Alison there, which reassures me that I'm remembering it correctly. So it's a key point that has to be addressed in any final devolution settlement, I guess, Sophie. Other contributions, please.
Norman, one of the undercurrents in the conversation this afternoon has been one of the issues that I think as a commission we need to make our minds up about. Harry concluded on his own view and the IPPR view that the way through on social care is national funding, and Phil's also made the same point in the course of the conversation. My own instinct, I have to say, is different. Because I think it's quite hard to see how you create flexibility between, on a Marmot-style agenda across the full range of public services, if what you do is create or actually perpetuate the NHS ring fence and simply extend the NHS ring fence to include part, but you'd never extend it to include all of what is in reality social care provided in the community. So I think frankly, it's the crunch question. Is the answer simply to extend the NHS ring fence to include a different form of care, or is it to rethink the way public services are financed, managed, and provided in a local community?
But just to develop that quickly, Stephen, would you advocate sort of going the whole way towards social care being financed through decisions made locally, or is it would you ultimately endorse some sort of balance between the national and the local?
Well, I don't think anybody's yet come up with a model of a revenue base in local government that would allow all local public services to be funded from that revenue base. So it has to be some balance. And it's why I made the suggestion during the conversation about digital infrastructure. That is a relative, in the scheme, it's a substantial amount of money, but in the scheme of things, it's a relatively small amount of money. And if that was explicitly and legally a joint responsibility, what you'd be starting to do is to break down the silos and make it impossible for the local agenda and the national NHS agenda to diverge, because they're both actually being built around the same information spine.
Yeah, well, I could see clearly that between us, we've got to resolve these dilemmas by the time we come to write our report. And that will be a fun process. And there will no doubt be a range of views. Can I have other contributions? We've got 5 minutes left. We don't have to use them all up. We can end early. But anyone want to make any final contributions?
Sean wants to come in, Norman.
Thanks,
John?
Steve. Thanks, Norman. Yeah, I think this is, I mean, Stephen's right to frame that as the challenge, I guess, for this commission and the report. But I would say that there are possibly areas where you could look to different funding models. So one of the points I put in the comment, apart from my poor joke about the price of London pints,
I did note that.
Thank you. A humorless, no response from the audience, but that's fine. I'll move on. There was is the notion of something we've been looking at is whether you can raise money nationally that can then be ring-fenced to deliver services locally. And in particular, we're looking at a tobacco levy that could be charged upon tobacco manufacturers that could then be used to fund smoking cessation services in that case, where there's a very direct link between the funds that's being raised and the services that are being delivered. And as Sophie mentioned earlier, smoking cessation is one of the things that gets cut because it is not a requirement to deliver, yet we know they're very effective. So there might be in the margins other mechanisms by which funds can be made available, particularly if we are adopting a sort of polluter pays principle, which I think will become will be something that government will be more engaged in the future given recent events.
That's very interesting. Thank you, Sean. And may I say, more interesting than your reflections on the price of beer in London.
Very fair.
Can I bring in Sophie next, please?
Yeah, I'm interested in that point, Sean. Also the beer one, of course. Now that nobody can go to pubs, the price of beer is the same everywhere. But that idea of polluter pays and then hypothecating the tax into something is actually just another form of centralisation, because it removes the opportunity for people to choose how to use their budgets. Because, you know, this bit of budget has to be spent on this and this bit of budget has to be spent on that. And you know, with one of the options that we could always have gone for with mental health is to say this absolutely has to be ring fenced, and we've always thought that is not a good idea, because actually people should be spending more on sometimes, and other people should, you know, don't need to be spending more. So it's attractive in lots of ways to get stuff off the ground, but it both reduces the opportunity to make choices, and it also leads people to think, I only spend on this what I get from a tax, and if I don't get enough in from a tax, I'm not going to spend on it. And that is quite a negative, starts a negative sort of process. So yeah, I'm always in two minds about that.
Thank you. Well, look, we're 2 minutes away. I mean, I would also make a final point, which I made before, about the value of international comparisons. I mean, you know, I do think, I realise that there's a limit to the amount of resource we have in this commission to do such work, but looking at other systems such as Sweden, where, you know, a lot of money is raised locally. You know, I remember when we visited and looked at their health system, we heard that actually most people only pay local income tax. It's fascinating. You only start to pay at a national level once your income gets to a certain level. I'm not making a comment about the effectiveness over all the outcomes that you get from one system compared to another, but I think it's worth us at least reflecting on how other countries do it. Particularly, I come back to what I said at the start, reflecting on how other countries have performed in the COVID situation, how their health systems have performed, and looking at whether more devolved systems, decentralized systems, have performed better than where there's been command and control. So look, I think it's been a fascinating discussion this afternoon. And if we finish now, we finish on time. So if I could just thank everybody, thank in particular our witnesses this afternoon, all of you, for your contributions. Thank fellow commissioners for your questions and those who've organised things, Steve in particular. And good afternoon to all of you, and see you next time. Thank you all.
Cheers, Norman.
Thanks, Norman.
On the 17th. All right, thank you.
Bye-bye.
Bye then.